Before I start today, just want to say thank you all for coming. I know it's also the mid-semester break and a lot of people are on leave. For those of you in the room that don't know me, I'm Ali, I'm postdoc research fellow upstairs in the Institute for Evidence-Based Healthcare. And I just want to acknowledge the traditional owners of the land on which we're meeting today, and which Rod's going to present to us today, the people of the Yugambeh language, and acknowledge their elders past, present and emerging. And also just note that we're joining on a beautiful sunny Queensland day, which we're all very used to, but I think Rod is very, very surprised the amount of sunlight that we get. He's probably got his yearly dose of vitamin D we were talking about earlier. But I had the pleasure of meeting Rod a few days ago at the Cardiac Society Australia New Zealand, and really, really excited for you guys to be able to hear some of his wisdom today. He spoke twice in our multidisciplinary stream, and I know everyone took away lots of really great knowledge and ideas, and were inspired by the work that he's been doing. So Professor Rod Taylor from the University of Glasgow, I would like to hand it over to you now. Thank you
very much, Alex. Thanks, Alex, and thank you for being my chauffeur and my minder for today. You've been great. I did the royal tour of the campus. So congratulations on what really is a very nice facility. I can see why you people want to live in this part of the world. Rainy morning in Glasgow seems a long way away, but the sun does shine occasionally, as captured in this slide. So really is a huge pleasure to be here. Many reasons for that, not least of which is Julie. Julie and I, how would we describe ourselves, Julie? Well, we're planets that orbit the sun. Every so often we get a chance to interact with each other. And I really do think that there's some really interesting stuff we could be doing more together. So we're going to have a chance to bore each other and talk about, hopefully, collaboration going forward, which is great. Just having some time to do that. So my background, just to help orientate you, bit eclectic. So originally medicine, didn't decide to do the clinical bit, but very quickly went on to do a PhD in exercise physiology. I was quite a sporty person, younger in my career. Very quickly pivoted because I realized that really what I like doing is numbers. So I'm a quantitative guy. So I then went to the London School of Hygiene and Tropical Medicine, did a master's in biostatistics, and then still not satisfied with that, just saying to Darren, I then went to Aberdeen and did a postgraduate diploma in health economics. So I am really a wee bit eclectic, but I describe myself really as a quantitative health service researcher. And I have the pleasure for my sins of going back to Glasgow. So originally a Glasgow boy, you might hear the twang, to head up our Robertson Centre for Biostatistics. That's our clinical trials unit in Glasgow. Also set up this new Centre of Excellence. I suspect Bond's not different like other places, you know, trying to bring people together. That can sometimes be quite challenging. So my job is to try and join together Glasgow together and indeed Scotland together in terms of our trials practice. And you'll hear some of that theme come through. So knowing that I was going to speak to you today, and Julie always is full of wisdom, and our wisdom was, Rod, don't overthink it. So I've tried not to overthink it, Julie, but what I want to try and do is talk to you about two of my hobbies, if I may. So one of my hobbies right now is the whole area of multimorbidity. And as you'll hopefully hear and understand if you don't already, I think it's a really key strategic challenge for us, for those of us who work in the health service research space going forward. The other hobby in my life is clinical trials. So what I'd like to try and do is use multimorbidity, multiple long-term conditions, or MLTC, all the same thing, as a vehicle to talk to you about what I think are some of the challenges in trying to design fit-for-purpose clinical trials. And as I say, it's just a vehicle, but it's been a bit of an issue for me because we have, and this will close off, a fairly large investment in UK and actually a mirror investment in Oz called Perform, where we've had to sort of work out how we do this. So this is a kind of story of work in progress, if you like, but hopefully will have some relevance for you given where you all are in the health service space within Bond. So that's the menu. Maybe let's kick off then, and please, by all means, feel free. This is a very informal setting, as far as I'm concerned anyway. Feel free to ask me questions as we're going, if you have any burning, but obviously if we've got some time, maybe Alex, we could do a Q&A at the end. So for those of you who don't know, multimorbidity has a variety of different definitions, but this is probably one of the most common. And essentially, it's not rocket science, it's the coexistence of two or more long-term conditions in the same individual. There is some clever thinking in the area. One of those, if you haven't read it, the Academy of Medical Sciences UK presented a report back in 2018, and our equivalent of PBAC in Australia is called NICE. Maybe a nicer acronym than PBAC. But basically they do the same thing. They make decisions around value propositions and whether we should be funding those in the public setting or not. They've been a little bit more restrictive about multiple morbidity. They've said that maybe we should be thinking about a little bit of heterogeneity. So maybe one of those long-term conditions should be a physical one, and maybe one could be a mental one. So in my space, I do a lot of work in heart failure, and as I'll show you later, many of my patients will also present with anxiety or depression, so they would be multimorbid, right? What's important, though, is to try and tease out what we mean by multimorbidity with comorbidity. So comorbidity is a term we use commonly, but if I put it to you, heart failure and hypertension, they would be comorbidities because they're innately related to each other, maybe even heart failure and atrial fibrillation. So they're comorbidities. But multimorbidity is really thinking about where the disease index is somewhat different to the other. And this pictorial that comes from that Academy of Medical Science document, of course, is trying to frame that we need to think about multimorbidity in a healthcare system where we've got issues like gender and age. Certainly frailty is another important factor, separate from multimorbidity, but often is in the space, and other personal related individual attributes, all that contribute to people's morbidity burden. So this is the kind of framing I'll talk about during this talk. Multiple long-term conditions, what's going on in Oz and New Zealand, and forgive me, those of you who are up in Brisbane, you will see a couple of similar slides. This is one of them. So about 1 in 5, 1 in 4 adults over 18, Australian or New Zealanders, will have multimorbidity. And you can see it's a ski slope. As you get older, somewhere about here for me, I've got about a 60% chance of now being multimorbid at my age. The other interesting thing, and again, this is data from your neck of the woods, if we look at the First Nation populations, no surprise that the prevalence of these conditions isn't just high in so-called white populations, but also Maori, Pacific and Asian, as shown here. And certainly that's very true in UK. You can virtually overlay a map of multimorbidity prevalence by deprivation index. And Glasgow in particular, we have a lot of deprivation and a lot of multimorbidity, and we've also got a lot of second, third generation Pakistanis, England, Bangladeshis, etc. in Glasgow too. And that prevalence is growing. So this is why this is a healthcare issue. And that's partly driven by the fact that we're getting older, and also the fact that, you know, medicine just keeps us alive for longer. So this is some of our data now, so bear with me if you would. So this comes from some large data work that we have. So we've got some large cohorts in UK. One is something called the SAIL database. It's actually a Welsh database of all things, but It has very good generalizability to UK. You can see the denominator. This is just in 55 to 73-year-olds. You've got some really solid numbers to be able to look at things. So this was an analysis done by one of our postdocs, Steph, in Glasgow, where she had access to this data and looked at the question of, if you have 2 or more long-term conditions, what happens to your risk of hospitalisation and mortality? And you can see perhaps not, oh, that was not good. I didn't want to press that button. I thought that was going to be the pointer. Oh, it's back again. Which one's the pointer, Alex? Is there a pointer on there?
Yeah, that's
Oh,
the big button. Perfect.
Yeah. You're the professor in the room. Great. So you can see that 2 long-term conditions, you can just see your risk sort of step function in both hospitalisation and mortality. And that's after adjusting for all of those sort of known confounders. So perhaps not surprising. But the other thing, of course, I'm particularly interested in my space is not just people's length of life, but the quality of that life. So this is data from another large observational database called Biobank. This is the EQ5D5L. For those of you who don't know it, generic quality of life measure. 1 is perfect health, 0 is death. You might want to think where you are on that curve at the moment, certainly dropping as Rod's presentation continues, but you can see if you don't have any multimorbidity, you should be about 0.9. But as we introduce long-term conditions, you can see again, there's that ski slope that we saw with event risk as well. So this is something that really fundamentally impacts people, whether we look at quality of life or the risk of events. And of course, things like hospitalizations drives a lot of cost burden as well. Now, one of the things that we did when we did this work was to not just say, well, does the number of long-term conditions matter, but does the pattern of long-term conditions you have matter? And we often call this clustering. So you can use latent class analysis. I must admit, I'm not an epi biostatistician, but there are some brighter people in my group that do this kind of thing. And what we've begun to realize is that we can identify certain clusters of long-term conditions. And these are ones that we identified from 2 different data sets, Biobank or SAIL, around morbidity. So for instance, it's interesting, isn't it, that if you have a cluster of substance misuse in mental health, I mean, you've got a 4.5 higher risk of mortality than some of these other things. So really vicious, nasty cluster to have. And perhaps not surprisingly, if you do have a physical and a mental combination, that isn't terribly great. And again, similarly, if you look at quality of life now, so again, 2 databases, there are, and the problem with this is, by the way, that notice that if you're using different data sets, you end up with different clusters. Ooh, that's a bit difficult. So you're somewhat dependent on the quality of the data in these data sets as to what comes out. But basically, I think that the takeaway here is that multiple morbidity is not great, and if you have certain combinations of things, that can particularly drive poor health or socioeconomic burden as well. So that's multiple long-term conditions, and I guess the question that is on your mind was on our mind when we moved into this space about 5 years ago is, well, what evidence do we have to manage people with multiple long-term conditions explicitly? So what I'm talking about there is that, yes, of course, we've been doing things for multiple long-term conditions in the past, but that's been happenstance. What I'm now thinking is that if we wanted to particularly address multiple long-term conditions purposefully, what sort of evidence do we have? And the answer is that there is a Cochrane review addressing that question. This is led by Susan Smith and colleagues. Susan's a general practitioner based Trinity College in Dublin, and her group have led the Cochrane review in this area. I think it's on its 3rd or 4th update now. important piece of work. And what Susan and her group have tried to do is to pull together evidence on trials, randomized trials, looking at different interventions, targeting people with long-term conditions. A lot of these trials have been done in primary care. So things like care coordination interventions, self-management support, and medicines management. Often these people are very much in, the problem of polypharmacy, the number of drugs they're taking. How do we give them interventions to help manage adherence and so on and so forth? But sadly, when you put those trials together, not that there's a huge number of them, but some of them quite big. So Chris Salisbury's trial, which was done in Bristol, it had hundreds of people randomized. Sadly, you can see that if you look at it, this is a mean difference in outcome. The diamond, the pooled estimate crosses zero. So we actually, and this is their conclusions, evidence so far largely negative. And they say that part of this is that not that it's the interventions that are difficult, well, maybe they're not optimal, but we have often very heterogeneous populations here. So yeah, conclusion from the Cochrane review, we're not doing terribly well in this space, so certainly more to do. So what I want to do now, if I may, is to sort of segue in this talk and say, well, if you were in my shoes, which we were 5 years ago, and thinking about trying to pitch a research grant into this space, what are some of the challenges? And I think there are some particular challenges in designing trials. I design trials for my living, that's my job. We've had to sort of, interact with some of those. So I thought it might be useful to maybe just talk about that experience with you. And I've broken it down into the classic PICO, people familiar with PICO, yep. So the population, intervention, comparison, and outcome. Just because of the constraints of time, I'm not going to talk about intervention development or comparator today. I'm going to focus on, how do we get people with this problem into trials? If we are going to get them in trials, how do we measure their outcomes? And then, perhaps not surprisingly, I'm a bit of a numbers nerd. I might talk a little bit about data analysis if we've got some time as well. So where we began was to try and say, okay, well, is there anything out there that could help us with this? And what we stumbled upon, and literally we stumbled upon these two systematic reviews. So these were systematic reviews looking at what we were interested in doing. And what I do are trials of exercise therapy, basically, either exercise alone or in adjuvant with other interventions like mental health and education. And one of these reviews is from just up the road or down the road, Melbourne group. So this was Catherine Barker and actually Anne Holland's group. I had the pleasure of going down and visiting Anne in Melbourne. And also this review from the Danish group, Søren Skue, Søren's MSK, physio based in Denmark, and he has a lot of interest in this area. Anyway, what we thought is that, well, let's do some meta-epidemiology. People familiar with meta-epidemiology? So the idea is that we use trials to help us think about research questions that might be of relevance to us. Maybe the detail that will come out will help illustrate that. And basically, when we put these trials together, or these two reviews together, sorry, we had 59 trials and about 29,000 people. So a lot of these trials individually were very small and don't provide definitive evidence addressing the question, but they do give us a kind of substrate to look at trial methods, if you're following me. That's the meta-epi bit. And of course, I get the privilege of traveling the world. These are the people who do the work. So James and Agnieszka are two of our postdocs. They did all the grunt work. They data extracted the 59 trials, pored over them, and basically put my pretty slides together for today. Thanks, folks. So here's our first slide. So this is just looking at, if you look at those trials, what were the inclusion criteria? So remember, multiple long-term conditions. So they had to have two or more long-term conditions. So what was the inclusion criteria, and what long-term conditions did they end up recruiting? And you can see it's really quite variable, isn't it? So diabetes certainly up there, hypertension up there, CHD, but a real kind of range of different multiple long-term conditions, and certainly gives you a perspective that I think one of the challenges in this space is that if you're recruiting patients, you could end up with very heterogeneous populations here. So all trials included 2 long-term conditions. Interestingly, a lot of these trials, though, you had to have a mandatory index condition. Sorry.
How do you differentiate or separate the co from the multi-morbidity? For example, obesity, like most of those conditions there.
Yeah. And yeah, so if you looked at table 1 in the paper, these were the conditions that they listed. I don't know if that answers your question. So it's maybe not getting as conceptually under the bonnet as you would like to get, but basically, did they say that obesity was either an inclusion criteria or they listed it in their table 1 and therefore included that population? So you could have both obesity and COPD and OA and cancer. Am I helping?
Yeah, just like, so diabetes, hypertension, probably hyperlipidemia.
They are comorbidities.
Yes.
Yeah,
yes.
Great, good. Okay, you're already at the takeaway
Yeah,
here.
so then
Sorry.
To be,
Yeah.
okay, the obvious ones is probably asthma or like depression, but that would be separate.
Perfect. So actually, a lot of these conditions are actually comorbidities rather than multimorbidities. And actually, this is what one of the findings that our 2 colleagues found here is that you had to come in with an index condition like COPD or heart failure and have one other, or a lot of these things are related to each other. So are they really comorbidity trials rather than multimorbidity trials? And I would put it to you, to be a multimorbidity trial, it should be agnostic of whatever long-term conditions people have, rather than saying that we want to do a trial on diabetes alongside other conditions. And a lot of trials like that have been done. I'll come back to that if I may, but so you're dead right. Sorry, it took me a wee while to catch you up. My brain's still over central Russia. I think it arrives in Brisbane tomorrow, just as I'm going home. So I'll pick it up from the carousel, pop back in. So the other area, if you think about it, that's really challenging in this space is, how do you measure outcome? So how could you measure outcome in a population where you may have very, very different people in terms of the disease status? So things like disease-specific measures are not going to cut the ice here. The good news is that there is actually a core outcome set in this area. So again, Susan Smith, she's a bit of a legend in this area, has created this core outcome set. So if you're not familiar with it, I would encourage you to look at COSM. And this is the items that are in there. And it's maybe just worth scanning your eye down there, because if you think about it, a lot of these things are quite generic, aren't they? So health-related quality of life, self-efficacy, physical function, they would cut across, wouldn't they? Individuals, irrespective of the specifics they might have. And indeed, this is a moving field. So one of the issues of COSM is it's very high income orientated. So fine for us in UK. As I was explaining to one of our colleagues, we're just about to do a trial in Bangladesh, India and Pakistan. So we are going to have to think about, do these core data sets globally translate? So we're doing some work with Fanwell Bicton, who's in Malawi, trying to see if we can revisit this to whether it holds up in these different settings. That's ongoing. So again, we used these reviews to do some meta-epi and say, what outcomes did they collect? So the first thing to say is they collected 219 outcomes across 53 trials, different outcomes, 200, a lot. what James did was to then map them, and these are the distribution of them according to the different domains. So I think that the size of the bar is the frequency. So certain things are dead common. So lots of these trials measure exercise capacity, but remember they're exercise intervention trials. So Julie and I would not be surprised by that. But certain things reassuringly are there, quality of life and others. We mapped them to the COSM, and these are the COSM domains. And you can see quite a few of them are picked up, but the frequency of some of these is really low and actually absent under certain of the domains. So things like shared decision-making, prioritization, communication, none of these trials actually measured any of those domains. And of course, the takeaway here is that we do need to think about generic health rather than disease specific. But of course, those of you who do trials will know trying to keep patients in our trials, one of the biggest issues is just the burden of what we ask them to do. So there's a sort of sweet spot here, isn't there? Getting enough information to cover their multimorbidity, but not so much that they're going to die of questionnaire-itis or whatever. This is another piece of work that's come from our group in trying to sort of think through the space. This is done by one of our really bright postdocs, Grace Dibben. So this was one of these horrible umbrella reviews. So in other words, you do a review of reviews. It's sort of Marquis de Sade type health service research. So poor Grace had to look at all systematic reviews across 45 long-term conditions. And bless her, this is her bubble plot. So you can see the different individual long-term conditions. So the most common ones in terms of the reviews were cancer, CHD, and painful conditions, things like OARA. And the size of the blob are the number of systematic reviews. And then the x-axis is the sample size of the largest of the systematic reviews. So what we did, and the question was, is that what evidence, and remember we were thinking about doing a trial in exercise-based rehab in long-term conditions. Which of these long-term conditions do we have pretty good definitive evidence that exercise is beneficial? And you can see the x-axis we've put in an ordinal scale, evidence of a positive effect. And anything in here, by the way, is a benefit. It's not that one to one side is more effective than the other. It's just all of these are positive. Unclear effect or no evidence at all. And of course, the takeaway that you very quickly get from this slide is that actually we had evidence that a lot of long-term conditions could actually benefit from the intervention that we were thinking about applying. And in fact, if they didn't have evidence, it wasn't that there was an absence of evidence, it was unclear. So you might say, well, why, for instance, is diabetes mellitus in there? Surely we've got very good evidence, but actually that's all based on HbA1c, largely, biomarker, rather than patient-related healthcare outcomes. We've actually included diabetes, perhaps not surprisingly, in our trial, but yeah. Another thing, just talking about one of the challenges of doing reviews in this area, and again, this comes from Susan's Cochrane work, is of course trying to do any kind of blinding in these kind of complex interventions is really difficult. You know, are you randomizing me to receive a physio or not? Well, I'm going to know that. But of course, what we can always try and do is to try and blind outcome assessment. But again, it's a bit of a challenge because, of course, if a lot of these are self-report measures, even although with blinded outcome, the outcome assessor, if we're doing things like exercise capacity testing, so we don't introduce observer bias, patients themselves will know. So issues like things like placebo effects are really difficult to sort of iron out here, and I know I'm preaching to the converted. So out of all of that, and the reason for all of that was this. So this is Perform, and this is a £5 million investment that the UK NIHR, so our equivalent of the US NIH, invested in us to really try and address this question. And as I say, it stimulated a lot of doing that background work because we want to first of all, developed for the first time what we believe to be a comprehensive exercise-based rehabilitation targeting multiple long-term conditions. And this is a collaboration where we bring together, you know, a lot of really bright people, led by Leicester, Sally Singh, Professor of Physio in Leicester, and myself. So far with this program, we've co-developed the intervention. As I say, I'm not going to talk so much about that today. We've done the pilot study. I'll show you a little bit on that. And we're actually right in the white heat of running the randomized control trial. Again, I'll show you the design. 20 sites across UK. We've recruited about 604 patients. Sorry, 100 patients and 604. And we've got 7 sites open. Yeah, about 100 patients recruited. So when we got this grant, I don't know if you get these sorts of grants in Australia, but this is what's called a program grant. And they're really nice because you get to do the big buggery trial, that's work package 4, but you get to do all of the preparation stuff that you should be doing before you get to do that trial. So what this is really saying is the funder's saying, we think this is a really important area. You need to nut out some stuff. And then if you nut out the stuff, all of these, well, certainly the progression from work package 3 to work package 4 is a very hard progression rule with the funder. You've really got to demonstrate you've solved it before you go on to the main trial. So a lot of this work I showed you earlier was done as part of that first year of work package 1. We could really get under the bonnet and try and understand this problem in a much better way. So this is just very quickly a little bit about the perform intervention, because I know some of you are interested in the exercise rehab side of things. So it's an exercise program over 8 weeks. If you're used to seeing cardiovascular, pulmonary, or even musculoskeletal rehab programs, it's very classic. So it's sort of mix of aerobic and resistance exercise. We've intentionally made the program face-to-face to begin with. We want to go digital, but we really want to know these are complex patients. They probably require a lot of supervision. We need to do this carefully. So this is the intervention we've developed. And what's been the real USP? Alex kept saying, Rod, what's a USP today? Unique selling point of this program is, I think, the health and well-being, because a lot of our cardiac and pulmonary rehab, the worlds that myself and Julie come from, you've got a particular condition that you're talking to. Here, you're talking to a lot of different long-term conditions. So our co-development with patients and healthcare professionals made it really clear to us that we need to be addressing some generic health problems that go along with multiple long-term conditions. Things like sleep. Actually, and we never talk about sleep in our cardiac rehab programs. Things like managing your pain, energy levels. So really trying to get at the generic elements of what people with multiple long-term conditions might have. And if you're interested, this paper was published while I've been out here. So this is our intervention development paper led by a really brilliant team in Birmingham. Colin Greaves has designed all of the interventions I've been involved in. He's a behavioural scientist, and also Paul O'Halloran. So we did this in parallel with Australia. You'll see why that is in a moment. So again, I think Julie was keen for me to talk a little bit about trial methodology. One of the really, I think, important things before we go into definitive trials is doing feasibility studies. This is the protocol for a feasibility study. What we wanted to do was to basically, in a small sample, 60 participants, 2-to-1 randomization. So what we're doing here are taking people with multiple long-term conditions, randomizing them to standard of care, and that would be whatever their medical management is for their condition, or usual care, and adding in the perform intervention. Yeah, it's an add-in. The population I've described before, but one of the things we've done is to specifically limit our inclusion criteria to one of those conditions that I showed you in the bubble plot earlier, where we had evidence of benefit. So we did use some of our work package 1 Interestingly, we didn't end up using any of the clustering information. We felt that that was too uncertain. Too many different clusters weren't consistent. Feel free to quiz me about that in Q&A if you like. And of course, what feasibility studies are about is whilst we will measure participant outcomes, they're not about looking at efficacy and safety. They're really about just checking that we can actually do the main trial and check its acceptability. So this is what we did. We screened 343 patients across 3 sites. Of 322, 60 were randomized, so that's a recruitment rate of about 20%. I mean, this is often quite an important thing to think. How many people are we going to have to screen to get one patient into the trial? If we get them into the trial, can we keep them here? Our retention rate wasn't bad, but if you look at it, it was very asymmetric. If you were randomized to the intervention group, yep, you were there pretty much at the end of the trial, but look what happened to our control group. We lost a lot of control. So this disappointment, if you happen to be randomized to the non-active, and we've really had to think about that for our main trial, how we get that number up. And then if they did get the intervention, on average, they attended at least 3/4 of the session, which is not bad in our kind of setting. I don't know if you do this in Australia. I'm sorry, I'll shut up. Go ahead.
Sorry to interrupt, but I was just thinking about what you mentioned before about the cluster analysis and the bubble thing that we saw there. I saw that cancer stood out quite as a big bubble. In other work that I've done on multimorbidity, we found that cancer really was in a space of its own. It doesn't play well with others. So I wondered, you've included cancer in there along with another multimorbid condition?
We did, and I'll show you the actual conditions we've recruited in a moment. But yeah, absolutely. So cancer's in there. And it's interesting what you say, because I think what you're intimating, and we do have some cancer-specific rehab programs in UK. So if you have some forms of cancers, you might get some form of prehab before surgery or rehab after, but it's very diffuse. But am I understanding your point right, that those sorts of people are different to those that we'd have in, for instance, a cardiac and pulmonary rehab program? Yes. Tell me more about your question. What you're thinking.
Well, I guess I don't know, thinking about the rate of drop off for your controls. Are we talking about people with complicated and end-stage conditions possibly included in this set? Because, if you've got COPD with cancer, then, if I'm enrolled in a trial and they're not offering me more days alive on this planet, then really I would find it hard to stay with it as well.
Yeah. Okay. So I think I can see where you're coming from. So I think what you're saying is that you could end up with some very different combinations of conditions in your participants at very different levels of complexity, at all sorts of different levels. So you're dead right. Remember, we're not stopping standard of care here. So if these people are on, their typical cancer therapy, we won't be stopping that. But of course, there might be a right point in their cancer treatment where they would enter the trial.
And then do you have the problem of exacerbation dropout? Like they're having an exacerbation of one of their conditions, therefore they can't actually do the exercise. They're in hospital this week.
Yeah. So I think what you're getting at, and I'm completely with you, is that to try and do this at scale with a variety of these different these conditions is not an easy one at a system level, never mind at an individual patient level. Or if you're a therapist at the front of the class and you've got 15 patients with all of these different conditions, how are you going to conduct that orchestra during a rehab program? Really quite fundamentally different. And I can see you grimacing at that, but yeah, it's bloody hard. But I'll put it to you, and maybe we'll come back, that at the moment, what are we better to do? Are we better to exclude those long-term conditions who just don't get rehab at all? Or are we better to sort of try and re-coordinate our systems? I mean, I wasn't really here to defend rehab in this setting. It was just, as I say, an example. But ultimately, that's the objective here. That's why we've been funded, is to say, can we disrupt the way in which we provide rehab services to ensure people get them in a more equitable way? But it's going to be really difficult to organise services to do it.
Yeah, but I guess the other, sorry, this will be the last thing I say.
Yeah, no, go.
But the other tension that you've raised here is, you know, how do you get it published? How do you publish something if you've got such a huge drop-off rate from your control?
Yeah. So you're talking about the 65%. Yeah. So the good news is we published the results of the pilot. But of course, the reason that we've been able to do that is that this is our feasibility findings. Yeah. So what we've done in the main trial is to look at strategies to now try and keep the control group in. So you're probably then saying, well, what are they, Rod? So things like we are now giving the control group a booklet on exercise. We didn't give them anything at all, so there's at least something that we're now giving them. And we've also got, going off in another direction, but I'll mention it, as you said, a SWOT running, study within a trial. So we're offering social media to people, whether you're in control or intervention, with the hypothesis that if you're in the social media group, you're more likely to be retained in the trial. And we're going to test that within the trial. It's actually our work package 5. So you're right. Are we going to be able to have good retention and controls at 12 months? The main trial's ongoing. I don't know. You'll need to bring me back in bright lights and rubber truncheons and ask me that question. I'm hoping we will, but it is a challenge. Yeah, conscious of time, but great questions. Thank you. So this is just the demographics of our feasibility study. And one of the things I just want to focus on is this. So any of you who are health economists in the audience, these kind of EQ5D values, I mean, I just don't see them in my trials. I do trials in heart failure. These are the lowest EQ5D values I've ever had in a trial. These really indicate very high burden of condition. And you can see that that's maybe not surprising, because these people have on average at least 4 long-term conditions, which, by the way, can include cancer. Yeah, as you said. And this is the distribution. It's a very busy slide. The paper, if you are interested, from the feasibility study, 2 papers, BMJ open, they'll be published in 2 weeks' time. The manuscripts are being accepted, but this is the distribution of the conditions that they have. So we've completed the feasibility study. As I say, we're now in the main trial, and this is just to show you the trial design. It's a bit unusual, the trial design, and the reason for it will hopefully become apparent in a moment. So what we're doing is we're screening for people who have multiple long-term conditions. So 2 or more long-term conditions, one of which has to be in that bubble plot distribution I showed you earlier. And the first question we say is that do they have an indication for either cardiac or pulmonary rehab? Because that's actually evidence-based care. So if they're post-MI, revascularized heart failure, COPD, we can't randomize them to no rehab. That would be unethical in UK, because cardiac pulmonary rehab is standard of care. So what we're doing is that they all receive the Perform Rehab program. And we will, through a prospective cohort study, compare them to real-world data collected from our national cardiac and pulmonary rehab audits. So we've got observational data on what are the outcomes associated with standard in pulmonary and cardiac rehab. So that's a prospective cohort. Not optimal, because of course we're going to have to do things like propensity matching, confounding control to do a robust comparison. If you don't have any of those cardiac or pulmonary conditions, we then can randomize these individuals to either receive intervention plus the usual care or usual care alone. Both groups, we assess them at 3 and 12 months follow-up, and the outcomes are the same in all of these 3 arms, both the randomised and the prospective cohort. And as I say, so far we've managed to randomise about 100 out of 600 in this group, and we're recruiting about 300, and we've got about 50 here so far, and we're about 2 months in. The problem here is not recruitment, by the way. There are tons of these patients. It's just the point that you've made. Some of them come in very complex. Now, why am I telling you about this? Well, one of the other reasons is that this has been a really fab, exciting opportunity, because the Australian government have decided to fund the exact same, or pretty much the exact same, research question. Don't know if you're aware of this. This is an arrangement between UK and Australia. We have it with other countries, you have it with other countries, but if a question is so fundamentally important, they will actually co-fund the trial, with the idea is that in the fullness of time, we might be able to combine the data across the 2 continents. So this trial is led by Anne Holland, who I mentioned to you earlier, based in Melbourne. And what Anne is doing is essentially addressing the same question, slightly different design. She's got 2 randomised control trials. So remember, this is a prospective cohort study in my world. Anne is randomising people to cardiac or rehab or perform. She got ethical agreement to do that here. We couldn't. And then doing the exact same trial as we are in people who do not have a cardiac or pulmonary diagnosis. What's interesting, and the reason I put this up there, is not only that we've got this great opportunity to run these 2 trials in 2 different parts of the world simultaneously, but the choice of the primary outcome. So our primary outcome in UK is EQ5D for our studies. Generic quality of life. Interestingly, the Australian funder would only fund Perform Oz on the basis of a hard outcome. So they wanted to see a reduction in hospital admissions. So for them, just moving the dial in quality of life wasn't enough. We want to see a hard outcome, reduction in hospitalisation. So this trial is recruiting 440 patients in Oz, but then pulling the data on all-cause hospitalisation from UK and Oz to give us enough power so we can then address that question. So again, here's a situation where we've got data being collected in 2 continents, but we will then pull it to address the policy question over here, which again, I think is quite cool. For those of you who know UK, none of you need to, but this is basically just the distribution map of where we're doing this trial. I mean, I'm kind of pleased because we've got a site up in Glasgow. We haven't quite opened yet, but we're about to. But I mean, basically the take home here is that we've been able to recruit pretty much across the country. And then the other interesting thing about this trial is that we're not just recruiting in NHS hospitals, but we're also recruiting in community-based settings. Almost there, Alex. This is the current situation in Australia. Just to say, Anne is still looking for recruitment sites. So if any of you are working with individuals or know folks who might be interested in joining in, then I think there's still a couple of slots available for the trial. Mentioned the primary outcomes. Of course, one of the things, and it's always a challenge with these trials, as you know, Rod does try and squeeze in a lot. So these are our secondary outcomes. A lot of these we're giving patients the option to complete before they come to their visit, so they can actually complete these all online. It's only the primary outcome they need to do in person. Why am I putting this up? Oh yes. So this is just to say there are some, in our world, some very interesting exercise-based trials in multimorbidity now ongoing. This one just published by the Danish group I showed you earlier, who'd done the systematic review. This is Soren Skue. This has just come out in Nature Medicine, and they've demonstrated superiority in EQ5D. So it looks like the world might be reasonably rosy. This is a yoga trial Gary Chu in UK just completed. haven't seen the results yet, and this is a trial that's, I think, still ongoing. So there are now starting to be trials in this area, and hopefully we'll get more information. So, okay, thanks for bearing with me. So what are some of the take homes here? Well, hopefully, you know, I've shown you that certainly multiple long-term conditions are one of those things that we really need to think hard and fast about. Sadly, so far, largely a lot of the trials have been neutral, but I think genuinely, not that I'm here to convert you to exercise-based rehab, but looks like it might be an intervention that may be promising here, but we do need that definitive trial evidence, and I think Perform UK and Perform Oz will contribute to that knowledge. Maybe taking it back to the trial methods area, I think, you know, there are some real trial design challenges in this area, population and outcomes. We didn't get on to talking about data analysis, but how do you handle the heterogeneity when you come to doing things like subgroups according to maybe different clusters? We are starting to think about how we might do that in our statistical analysis plan. And then I think hopefully also demonstrating that, you know, we were really starting from scratch here. So using previous trials to do some meta-epidemiology to sort of help and inspire you to how to go about things. So you'll be glad to know that's me finished, and thanks for bearing with me.
Thanks, Rod. And not to wrap you up, but my watch decided to send me an alarm to say, get off your butt. So that was a good time to stand up.
You were right, stop. Thank you.
So I'm just going to use the microphone purely for the recording. Did anyone have any questions, remarks for Rod? Julie, did you want to go first, or shall I do
Go first?
Okay.
Yeah. So mine isn't really a question, Rod, but thinking about your talk was really what I wanted you to do to show the breadth of what's required to do a clinical trial to solve a major problem. And you've been able to have a program grant to do work packages. But I think here at Bond, we need to do better and understanding how there's a whole steps to a bigger picture when you're designing a clinical trial and being very robust about it. And I would like to see us here at Bond be able to be more strategic in how we're thinking of how we're going to solve this big problem. What are the steps to get there? What are the reviews? What are the feasibility studies? What are the co-design strategies? And you've done all of that. And I guess for me, it's a comment to everybody here. This is something we need to think about if we're going to be able to deliver groundbreaking research here at Bond University. So you have showed that through a program grant. Now, you don't need a program grant to do what you've done, because you can have a PhD student delivering work package 1, working with an honours student, doing some of the co-design, and a postdoc. So there's a few ways to do it, but I guess that's just my comment to sort of think about the higher order, delivering a big program of research leading to a large clinical trial.
Great comment, Julian. And just to say, program grants are rare beasts in UK as well. You don't often get big buggery sums like this. So typically you need to do these as kind of one step at a time, either in parallel or in series. So just to be clear, you know, you might, and I think there are some themes to Julie's point here. So doing some large data population work, doing systematic review work, you know, doing co-design. I mean, each of these could be funded as separate pieces. And as you say, if you can get them into PhD postdoc programs, it becomes doable. But the point is that I guess we're on the same page. You can't just go straight to here. Well, you could, but you're almost certain to end up with a neutral trial because you just haven't nutted it through. So you're right, this is an unusual formula, having a program grant, but I would put it to you, and often we do, you know, we'll go for wee grants, plug these into PhD programs just like you would in Bond. And I think the idea is to think, well, what are the bricks that you need to have to go to get, you know, the definitive trial funded and have a really strong argument to get that, you know, $2-3 million trial funded. And you often have to have these elements as part of your application to achieve that. Yeah.
Thank you. It was a really nice talk. My question is more related to, because I've seen the comorbidity and multimorbidity as well, and often we have also sometimes defined the window, like if the second disease is happening within a year or 2 year, are we going to consider this a comorbid? Like for example, like flu is happening 2 or 3 times sometimes for within a year. So we have developed a disease map based on the Taiwanese data, and we visualize the outpatient data that how these comorbid diseases are within the certain time frame in the different age groups as well. So my question is more related to the medications, because I haven't seen mostly sometimes what happen is it's not because of the diseases related to another disease, but also because people are taking medication, which is actually more likely to reduce immunity and things, and then they can able to get the other diseases like cancers.
Yeah.
So we have done some research, for example, and there's an evidence for benzodiazepines. Let's say people are taking for more than 2 months and they ended up having some cancers, but they are not aware of. They think that it's because of maybe other diseases are likely to have. But on the other hand, some medications also have to reduce. So how do you see in this kind of thing, like where this sits as well? Is there a gap, or how we can able to identify that to bring those things into this as well?
Yeah. Well, I'll be honest, I'm not quite sure if I'm the right person for you to be able to answer that question authoritatively, because to some extent, at least within our Perform trial, we've kind of left standard of care to whatever's happening within that space. Our question is, what's the incremental value of adding in a comprehensive rehab program, whatever people's standard of care? And we kind of got into that a little bit with cancer. So these people may still be under the cancer team, and they'll come and receive this intervention on top of that. But as you say, I mean, the polypharmacy side of things and the interactional effects of some of those treatments is yet just another area of complexity. It's not my thing, but I completely get where you're coming from. And in trying to do that, again, you can see some of those earlier interventions I showed you from the Cochrane review, where we're thinking about particularly the drug side of things. And I guess one of the questions is, if you end up with so many drugs, of course, could they actually be competing against each other in some different ways?
Are you recording the meds with your patients?
Yeah, so we have to, because our health economist insists, because we want to look at resource utilization during the study. But yeah, what we'll do with that data, other than drive the health economics beast, I'm not sure, but it sounds like it will be important to take, to see what is that complexity of medicine at baseline, but also, do we have any impact over the duration of the trial, and what might be changes within that medication space? I mean, we're not hypothecating we would, because we're adding to standard of care, but maybe we will.
Thank you.
Yeah.
Thanks, Rod. That was great. Thank you. 2 questions. One, just very quickly, in the systematic review, I think the Cochrane you were talking about earlier that kind of mixed up co and multimorbidity. Did they do a separate check of just the true multimorbidities, and did they come up with a different result?
I don't think they did. So in other words, did they do a stratified analysis according to whether it was comorbidity and multimorbidity? I don't think so. I mean, that commentary you saw on comorbidity and multimorbidity didn't come from them, that came from us. So I don't think they recognise the problem, so to speak. So when they were including trials, I guess their inclusion criteria were such that if I was doing that review, I would have not included the comorbidity trials. I would have just included the multimorbidity trials. To your point, we've got a student now doing that prospective, as some of these trials, such as the Danish one I mentioned in Nature Medicine that's just been published, and starting to now prospectively track the true multimorbidity trials happening in this space. And obviously Cochrane have for some time. And we'll try and bring the two together at some point when we've got enough evidence to maybe collate that again.
Cool. Thank you. And secondly, it's probably a heterogeneity issue, but exercise or activity doesn't exist in a vacuum. So your control will have most likely immense variability in their lifestyle and exercise levels. I'm curious in terms of your trial design, how you're accommodating that.
Maybe not terribly well will be your conclusion when I tell you. I mean, basically, we're just observing it. You know, genuinely, you know, we're randomizing them to control, and obviously we had this bit of a bump around loss and retention in control groups. So we are giving them at least something, which is, you know, some structured advice around being more active and being more healthy. One of the things I'm quite pleased about, and we've got it funded, it's an example of Julie's point, that this postdoc Grace, she applied for just a small grant, her first grant, to do a sub-study of accelerometry, where we're going to monitor trial population, both controls and an intervention, over the duration of the study. Subgroup, we won't do it in the full 603 patients. I think it's 200 patients, 100 in each group. But we'll be able to look at the question of, are we able to improve objective physical activity in the intervention group, but also what happens in the control group? You know, and even what is it at baseline? So even just doing the baseline study, you know, measuring physical activity in 600 people with multiple long-term conditions, I don't think anybody's done that terribly well so far. And what might be the heterogeneity you will see in different lifestyle patterns, even at baseline, even before we randomize them. So I'm hoping that accelerometry data that we'll be collecting in every patient, you know, will be a 7-day monitoring baseline, 4 months follow-up and 12 months follow-up will be a rich data set to try and get at that, but not a lot more. We're directing the control group to, we're intentionally leaving them to their own business, pragmatic trial. Thanks.
I'm just mindful of time. It is 12. 5 people have like waved at me, but I'm going to question this 2, because particularly because one's not based in our institute, but the institute-based people, except for Ayuka, because Ayuka's waved at me first, perhaps can come and approach you at lunch or afterwards, because you'll be here for the afternoon. So I'm going to throw to Ayuka, and then I'll throw to Justin, because Justin's our Dean of Research, or Associate Dean of Research for the faculty as well. So he's not part directly of the institute, but that's just to orchestrate and to note that I've noted all your
Stratification going on there, right? But yeah, I'm around at lunchtime.
Work, Ellie.
Yeah, very good.
Thanks, Rod. It's great to see that the multimorbidity patients are getting some attention finally, because in real life, there's hardly anyone that has a nice little single health issue. Everybody's got, you know, several health issues, especially, you know, the older you get. And in terms of exercise intervention, we are the converted, you know, you're pretty converted. We have this thing called Handbook of Non-Drug Interventions, and exercise is included in one of the things. And for breast cancer population, where, you know, the outcome is much better if those cancer patients had exercise and stuff. So my question, I have 2 questions. Number 1 is, you said you chose, well, you included those conditions that were, that shown to be effective. If the exercise was kind of quite effective from the bubble graph, right? Yeah. Why chose those conditions again? Because have they already shown to be, you know, benefiting from exercise? Why didn't you choose the unclear evidence area?
Yeah.
Disease?
Okay, so that's a good question. We took a pragmatic decision. So our question was if we bring together multiple long-term conditions, maybe we only should bring together at this stage multiple long-term conditions where we know at least one of those has evidence on its own of benefit for exercise. Now, shoot me down. That was our decision to do that. And I think the reason we decided to do it is that we didn't want to end up with yet another neutral trial. And if I'm very honest with myself, so one of the risks, if we had put in, you know, some of these long-term conditions where there is no or emerging evidence, they may not have improved with exercise. And of course, the more of those that we'd have in the trial, the more we are going to move towards a neutral mean null effect. So, you know, just somewhat cynically, we included them because we want to see an effect.
Thank you. Question number 2 was, you said in the UK, the program grants are given not very often. Then what other grants are given more often than that?
Yeah, so that's an interesting question. Again, we could talk about that over lunch. So
sure, definitely.
We are very fortunate in UK at the moment that we have a whole variety of different funding that largely falls under this umbrella called NIHR. So very quickly, NIHR fund trials of drugs and non-drugs through the health technology program. They fund randomized control trials of system level interventions. So, maybe introducing a specialist nurse for disease management and comparing that to usual care. We call that HS&DR, Health Service and Development Research. And then we also have program grants that lets you have these larger sums of money. And then we also have another area called global grants, where you basically do research, but not in UK, you do it abroad. And where you can pitch to kind of depends on your research question. And we also have some small grant funds. So they may fund up to £250,000 for 3-year investment to do some of the foundational work, where you would then put together a full application to those more mature boards that I've to describe to you. Hit rate, if you're going for the big boards, 1 in 10. So for every 10 applications, it was in about 1. For the smaller grants, about 1 in 5. So it's doable. And certainly we want more money, but we've been quite fortunate that our government has worked out that for every £1 they invest in health service research, they get £2.50 back again. So they've done the economic analysis. So we're benefiting from quite a good investment at the moment in the health space.
Great, thank you.
Thanks, Rod. Last question. I have read that bubble paper, so I was interested to see that one again.
Sorry about that.
That's good. But in terms of the exercise component, I had some questions relating to, so there was a paper from Escobedo's group, like a position statement on benefits of exercise. It was like 60, 70 pages long, that went through a lot of those sort of best forms of exercise for different conditions. So when you've got these multiple conditions in individuals, and in some ways cardio or resistance training might be a better in general, but again, there's different outcomes and side effects or treatment related effects, say for prostate cancer or something. How are you sort of ensuring that the patients are getting a very good exercise prescription for their multi conditions, but still minimizing the risk of any sort of issues that someone with knee osteoarthritis or bone metastases is having?
Yeah.
How is that sort of benefit to risk ratio sort of being optimized at each individual patient level, but then still allowing you to write a method section and an exercise prescription within the paper that it could then sort of be replicated into the future if you are successful?
Yeah, that's a really thoughtful question. Well, okay, so I mean, just as a vignette, I went to the Royal Brisbane Women's Hospital and saw their second patient being recruited. I won't go into details, but I'll just say in brief, the screening assessment that they did around that individual was 1.5 hours, 2 hours. So really forensically getting into, what conditions does that individual have? This was being done by a physio, and the physio was kind of working out in real time, how am I going to plug that person into a group-based program? Are they going to be able to do, so this individual had a lot of painful lower limbs, so maybe they're going to be more on the rower and more on the bike than they are on the treadmill. But that real-time processing was happening. I could see that. And that was just one example, because I'm not delivering the intervention, so I don't get to see the reality. But so I think that's the key bit here. If we're going to do this well, we do need to have some system of personalising the research offer at quite a granular level for people, as we've discussed, who can be very, very complex, and then delivering that in a group session setting where it's going to be safe. I think we're all saying that's really quite a tough ask. And what was very interesting in our process evaluation of our feasibility study was that was the key bit of feedback. So the primary people delivering these are physios and nurses. That's the UK bread and butter in terms of cardiac rehab. And all of them were well outside their comfort house, their wheelhouse in terms of their exercise offer, because a lot of them were cardiopulmonary advanced, but not in these other areas. So I think that's the genuine challenge here, is how do we skill up a workforce that can do this effectively and can do it comfortably. So to come into the Perform programme, not only do you have to be an existing a person who's already delivering these services in a single long-term condition, but you then need to go through a one-day webinar program that's being run by Colin, the guy who developed the intervention, and his team to skill you up on the multimorbidity piece. And I believe it's the same in Australia. So Paul O'Halloran, together with Anne, either face-to-face or remotely, are adding in those additional skill sets, both exercise rehab, but other bits of the health offer to do things more effectively generically. Does that answer your question?
Yeah, it does. Again, it's a complex challenge, and probably one of the reasons these trials haven't really been done before.
Yeah. And it may be all too difficult. I mean, that might be where we end up here, that this is, whilst conceptually, Professor Taylor, it's a lovely idea, you know, to operationalize this on the ground, it's just too difficult, or we can't scale it, you know. But yeah, I guess that's why we're doing the trial, right?
Yeah, well, congratulations on getting the funding, and all the best with what will happen in the next few years.
Yeah, thanks a lot.